afternoon, rebels. I do come from the world of medicine. I'll tell you a bit about it. My education actually began in Mississippi, sitting in front of a church nights with Cat Reed, a local teenager, with shotguns on our laps and smoking cigarettes to stay awake, I confess then. The year was 1965. The place was Holmes County, Mississippi. And I was a civil rights worker for the Medical Committee for Human Rights. I'd been sent south to work in that community. The church had been firebombed a couple of weeks before, and the community was decided to defend it, unsuccessfully firebombed, I should say. A medical civil rights worker then really was unprecedented, and there was no job description. You did what the community needed, and what they needed then was guarding the church. Now, Cat Reed and his family really had no medical care, as did most African Americans in that community and those like it in segregated 1965 Mississippi. Should get this up here, that was back then. Some years later, working as a National Health Service Corps physician in northern New Mexico, I was in the emergency room one day, and a doctor approached me, a Dr. Menges, and he said, "Mullan, you know I was against you coming here." Now, at that time, the National Health Service Corps needed to get the approval of the local medical society in order to place a physician in a community. And I'd heard there'd been quite a fight about that. So I said, "Yes, Dr. Menges, I had heard that some folks were opposed to my coming." And he said, "Yes, but I want to tell you, Mullan, I was wrong." I said, "Really?" He said, "Yes, I have a lot of deadbeats in my practice, and you've taken them off my hands." Now, the world of deadbeats and good patients was kind of part of the environment of, this would be the 1970s, in a country in which we had no national health insurance, and many patients, of course, were uncovered, uninsured. Deadbeats, perhaps. Some years later, I practiced pediatrics at Upper Cardozo Health Center of Unity Healthcare, about 2 miles from here. And during those years, I always practiced with residents from GW, Children's Hospital. They, being a part-time practitioner as I was, they would keep me up to date on, say, the latest antibiotics, and I would teach them community medicine, and particularly something that we called tin cup medicine. So as a primary care center, we had a great staff, good facilities, and we provided primary care. But as soon as a patient needed a CAT scan, or a mental health consult, or a cardiac evaluation, et cetera, our uninsured patients were simply out of luck. And we would go to the phones and start begging. We'd call Catholic Charities, we'd call local hospitals, practitioners, clinics, and we had a whole list and updated it. This was tin cup medicine. I taught it, practiced it, and taught it as part of what you do when you're practicing medicine in America, particularly in less well-to-do communities. Inequity in the health system has been there since the beginning, certainly in our country. We're struggling with it, we have struggled with it. But if you look across the spectrum, infant mortality rates, longevity rates, death rates, differentials in diseases and disease burdens. If you look between the rich and the poor, between the insured and the uninsured, the differentials are everywhere and substantial. Now, as custodians of the systems, we physicians practice amidst this. It isn't our fault, but we are certainly witness to it, day in and day out, not just in poverty clinics, but throughout the system. We are witness to it, and we participate in it per force. And this is a challenge for us. Now, I want to flash back 100 years to a gentleman named Abraham Flexner, who in 1908, he was an educator. In 1908, he was commissioned by the Carnegie Foundation to travel the country, visit all the medical schools, and issue a report. And he did that in 1910. His report had a seismic effect. Words like ignorant, fetid, disgusting were frequent throughout this report. What he found was medical education in a variety of settings, many of which were proprietary, for pay, mom and pop operations that were essentially science-free zones. Now we're talking 1910, and science coming out of Europe in the late 19th century, late 1800s, was washing into America, but it hadn't really hit the medical schools, many of them. The effect of his report, however, was profound. In the following 20 years, more than half the schools closed. And his prescription was that medicine should be taught in the research university. It was a brilliant, simple, but brilliant proposal, because that is where science was respected and practiced. It was a quality assurance vehicle. But the unintended and unforeseen consequences of that has been to consign medical education to one kind of institution, which today has grown into the academic health center, the large teaching hospital. Spectacular institutions with a number of missions. First among them is service, largely of a specialty and subspecialty nature, quaternary care and tertiary care as it's called. Secondly, as research institutes where much of the cutting edge research takes place. And often medical education is a bit of a sidebar that is respected, but part of the passing job of the institution rather than a focal one. So our medical students are essentially directed through institutions that are extremely intensive, extremely expensive, and distant from, at least culturally, from the community where most of medicine continues to be practiced. So Flexner was very strong on the quality mission of medical education, but his work really distracted educators and others from the social mission of medical education. The social mission, as defined, is the mission of a medical school in its contribution to the programs and the performance of its graduates in addressing critical and unmet health problems of the society in which it exists. For society, read neighborhood, community, region, state, perhaps nation, perhaps world, although I get worried when institutions don't have a basis that's closer at hand. The social mission speaks to community engagement. It speaks to disparities reduction. It speaks to diversity enhancement. It speaks to concern with cost. And it's the whole agenda chasing down the social determinants of health, which are out there in the community and determining a lot about what we as individuals and we as a population suffer from in terms of health. That is the social mission. Now, it's not prominent, as I say, in many of our institutions, but fortunately we have a number that have kind of moved beyond Flexner or are hot in pursuit of social mission, and they provide inspiring examples for the rest of the system. Let me give you a couple of examples. The University of New Mexico in Albuquerque is a school very much dedicated to that state. Most state universities are, but the dedication and scope of that intent in New Mexico is quite extraordinary. Among the many programs they have it's called a BA to MD program, which recruits kids out of high school. And they go around the state to the poorest high schools, often in the state, but the high school level, and select kids who have promise for entry. And if you succeed at the college level, you're automatically admitted into the medical school. And currently, a quarter of their class are participants in the BA to MD program, and they are heavily Latino American and Native American, and it really provides an important pipeline into the school for minority students and disadvantaged students. Morehouse School of Medicine, one of our proud historically black schools in Atlanta, has a number of programs, as you might imagine. They specialize in pipeline programs. The term pipeline refers to reaching out into the community and developing early enhancement programs in K through 12, in elementary school, high school, and in college, in an effort to reach out to students who have promising but not necessarily well supported potential for health science, for medical school, and other health schools. And these programs of a variety of sorts help these kids along, create, a larger pool for Morehouse itself, and create many opportunities for those students in other schools and other professions. Finally, the A.T. Still College of Osteopathic Medicine in Mesa, Arizona, an osteopathic school. Osteopaths have pioneered many creative, educational, community-oriented projects. They admit students for 1 year, the basic science year, to the Mesa campus, and then send them to one of 11 community health centers around the country, one here at Unity in DC, for the latter 3 years of medical school. They do distance learning for basic training back at Mesa, but they do their clinical work in the community health center and in local teaching hospitals. They are trained as community physicians in the community. It's an extraordinary program. It's succeeded very well. They have 4 or 5 classes of graduates now out practicing, most of them in primary care, most of them supporting communities that are disadvantaged, working in them. So these are examples that can set the style and the pace for the rest of education, medical education, if taken seriously. We have an opportunity to make a choice about the future. In 1900, in Flexner's time, an American-born could expect to live 47 years. In the year 2000, an American-born can expect to live 77 years. That's a 30-year jump in life expectancy over the course of a century. Unprecedented, extraordinary. The result of public health and medicine and science and the population. But that's a tremendous achievement. A problem for us not to forget, however, is that achievement is not uniform. Great disparities remain within the population. And just to biopsy a few, blacks will tend to will on average live 5 years less than whites. If you were born in Connecticut, you're likely to live 6 years longer than if you were born in Mississippi. If you have health insurance, you'll do better and live longer. And if you're born in the United States, you're likely to live decades longer than if you were born in sub-Saharan Africa or many developing countries around the world. So the gaps, the disparities are internal and external, and they are dramatic. So the question that leaves us with, me, with you, particularly the students in the room who will be largely the stewards of the 21st century, is what's our goal in medicine? And how do we set that in medical education since we set sail from the medical school on out into practice? Is our goal to see to it that the privileged people in the United States put 30 more years on and live on average to be 107? Or should we think about our priority being the earnest, serious, durable disparities within this and move the floor up as our goal? I think the latter is what I would certainly suggest to you. We have an exciting and doable agenda, but it means setting our sights on doing that. It means moving beyond Flexner. It means moving now and moving together. Thank you.